So, good afternoon, everyone. My name is Luis Cardoso, as you know, or at least most of you. It's a pleasure to be here to open this course on the 77th annual meeting of our society. First of all, I would like to thank Ascendis for putting together this excellent group of speakers. You will see that the speakers are one of the best around the world in this field, and you will have the opportunity to share your experiences with all of us. Second, I would like to thank Ford Society to open this slot for us to have this course. We usually have a full room for hyperparathyroidism. On the hypo-PT side, generally, we do not have a full room of people interested in this topic. So it's a pleasure to see so many people interested in this very specific topic. So this course is entitled Bridging Science and Care in Chronic Hypo-PT in Adults, and it's in fact what we will be doing here because there is a significant gap between what we know on the science side and what we do on our clinical practice. So we know a lot of how we should treat these patients, but the hormonal therapy is not yet of widespread use in our clinical practice. So we will try to fill this gap today. We will talk about pathophysiology. We will talk about conventional management of hypo-PT. We will talk about more advanced therapeutic options that are emerging right now. We will talk about complications of hypo-PT and artificial intelligence. So the format was designed to be interactive, so we hope that we could fulfill your requirements and your needs in this field. And for the sake of time, I will now present the first speaker. The first speaker is Stefan Pils, a very good friend. Is from Graz, is a professor of endocrinology at the University of Graz. Is very interested in the areas of vitamin D and hyperparathyroidism, hypo-PT, and he is the past president of the Austrian Society of Endocrinology, so he knows very well how the workload to organize this kind of meetings. Stefan, the floor is yours.
So, thank you, Luis. Relax. Thank you also to everyone who is attending this symposium. Also, relax. I will start with the easy, basic stuff. The more complex things will be covered by my experienced colleagues. So, my topic will be to introduce you to chronic hypo-PT from the view of pathophysiology and diagnostic precision. And I will very much in this talk refer to the new guidelines that we drafted together with some of the colleagues that you will hear later on. And we hope that this guideline is useful for you. To start this presentation on hypo-PT, it's always good to look at basic physiology. So what you see here is the thyroid gland, and you see the parathyroid glands. And what they are doing is they measure the calcium. The free ionized calcium is measured via the calcium sensing receptor. And if the calcium is high, this receptor is activated and it suppresses the PTH synthesis and secretion. If the calcium is low, then PTH secretion is stimulated because PTH in turn increases calcium or maintains calcium within a physiologic range via its effects on the bone, we have bone resorption, and also via the effects on the kidney, we have increased calcium reabsorption in the kidney and decreased phosphate reabsorption. So it keeps the calcium in and the phosphate out regarding the effects on the kidneys. But PTH also does have a very important effect on vitamin D metabolism. It stimulates the conversion of 25-hydroxyvitamin D into calcitriol. This is the active vitamin D hormone, 1,25-dihydroxyvitamin D. But it's not only about calcium, it's also about phosphate when it comes to PTH regulation, because we know that phosphate also stimulates PTH secretion, and this has been nicely shown a few years ago. So this is one of the reasons why patients with chronic kidney disease, they tend to have higher PTH levels because of the high phosphate that stimulates PTH, but because also of other reasons. There's some kind of PTH resistance in these patients, and also there's a decreased clearance of PTH fragments. But it's not only about calcium, not only about phosphate, it's also about magnesium. So when you approach these patients, magnesium plays also a role in the regulation of PTH secretion, and both, if you have too low magnesium, it suppresses PTH secretion and also its effects, and the same in a similar way applies also when you have too high magnesium. So always watch out also for the magnesium in these patients. From a perspective of an endocrinologist, when we look at hypo-PT, it's not only a deficiency of one hormone, we have a deficiency of two hormones. As you can see here, we are not only missing the PTH effect, we are also missing the effect of the active vitamin D hormone because, as shown in the previous slide, PTH stimulates the conversion of 25 to 125 dihydroxyvitamin D. So this is just a basic view on this disease, and whenever we talk about the disease, we have to come up with a clear definition, and according to the guidelines, what you see here, a diagnosis of chronic hypo-PT is made in a patient with persistent hypocalcemia, this is the hallmark of this disease, and inappropriately low or inappropriately normal parathyroid hormone, PTH levels. So in other words, you can say calcium is low, PTH is low, but don't fall into the trap when you have a normal PTH level and you have a severely reduced calcium. This is not signaling a proper function of the parathyroid gland. So whenever you have a constellation of a reduced calcium, the PTH is expected to be elevated. If it's normal, this is a typical sign of hypopara. There are other parameters you can look at in your patient to support the diagnosis. You have increased serum phosphorus in many of these patients. PTH keeps the phosphate out, so if this is missing, the phosphate is higher. You have increased urinary fractional excretion of calcium because you have this problem with the reabsorption, and you have usually low bone turnover markers and low 125-dihydroxyvitamin D, though this doesn't play a role, the measurement of calcitriol, in clinical routine. So stepping back, going to the basics, the message I want to deliver, always look at calcium and PTH in combination. And when we zoom out, both is low. This is the typical constellation for hypopara. When we have a low calcium but an elevated PTH, this is indicative of secondary hypopara. It may be due to vitamin D deficiency, to gastrointestinal absorption problems, and so on. There are always exceptions. You will hear later about pseudo-hypoparathyroidism. When both is high, calcium is high, PTH is high, this is typical for primary hypopara. And when we have a high calcium, a low PTH, this is PTH-independent hypercalcemia. This can be due to malignancy, due to sarcoidosis, but also due to immobilization. Think about the emergency room. So with this, I want to concentrate on the calcium measurement, because this is in the center of hypo-PT care. But what do we actually measure? And when we look at calcium as a whole, so this is the total calcium, half of it is bound to proteins, mainly to albumin. Then the other half is mainly free, or the ionized calcium. And in clinical routine, when we look at the lab reports, we get these different measures of calcium. We have the total calcium, we have the albumin-adjusted calcium, and we have the ionized free calcium. What to do, which parameter to use in clinical practice? That's a critical question. There are pros and cons of all of these different measures. Of course, ionized free calcium is the biologically active gold standard. This is the fraction that matters with regard to biological effects. And in a perfect world, we would always use ionized calcium. But it's not available everywhere. There are some pre-analytical, analytical challenges with this, so there are also some limitations with the ionized calcium. The most widely used parameter is, of course, total calcium. That's what you get from the lab in most of your hospitals, but there are limitations with total calcium. One being that is dependent on the albumin level, in a way that the lower the albumin, the lower the total calcium. And the problem can be when you have a patient with hypalbuminemia, so with low albumin levels, you measure the total calcium, it is reduced, but the ionized free and the relevant calcium measure is not influenced by albumin levels. So that's a huge limitation of total calcium, and therefore albumin-adjusted calcium level was invented many years ago. Formulas were developed to calculate and to count for the albumin level, and these albumin-adjusted levels, calcium levels, have been used for many years also in the care of hypo-PT patients. But we have several studies showing that the hope that this will fix the problem with the albumin-adjusted calcium levels wasn't really the case. So in many studies, we didn't see a huge advantage of using albumin-adjusted over total calcium levels. So there is some discussion ongoing also in the scientific literature on how to deal with these three different parameters. However, I have to say, most of the evidence for hypo-PT is based on ionized and or albumin-adjusted calcium level. And we got some criticism regarding the guideline and how to deal with this. And this is our answer. So you can use, and this is a takeaway, free calcium, albumin-adjusted calcium, but you can also consider to use total calcium for the care of patients with chronic hypo-PT. But the takeaway message, and this is very critical, is we want to emphasize that ionized calcium, when feasible and reliably measured, should be the preferred assessment when you have challenging cases, critical cases, when you're unsecure on the diagnosis. So this is the takeaway for this. And with that, I move to epidemiology and to etiology. We know chronic hypo-PT is quite a rare orphan disease, but as endocrinologists, you will have to take care of those patients. This is a chronic disease. This requires lifelong treatment. But what is the main cause of this? Well, the main cause is due to anterior neck surgery. So it's mainly about thyroid surgery causing, as an adverse effect, chronic hypo-PT. And to illustrate the risk of hypo-PT with thyroid surgeries and the disease course, I have this figure here for you that's drawn from the guidelines based on a systematic review of the evidence published. And here you see when you have more than 8,000 thyroid surgeries, about 1/3 of those patients will have some kind of hypo-PT, hypocalcemia immediately after surgery. However, most of those patients will recover within a few weeks, so that of those patients who suffer from hypo-PT immediately after thyroid surgery, 73.9% will have recovery at 6 months and a few additional percent after 12 months, so that at the end of the day, about 6% of all patients undergoing thyroid surgery will suffer from chronic hypo-PT. So for your takeaway, avoiding unnecessary thyroid surgery is very critical because there is a risk for this. And because of this potential for recovery, the diagnosis of chronic hypo-PT should only be made at least 12 months, 1 year after thyroid surgery. So with this, I come to the other etiologies. What is if the cause is not thyroid surgery? And as you can see here, there are a variety of diseases that can cause hypo-PT. don't worry, I will not go through all of them. Just mention the most important ones. It can be autoimmune, it can be a genetic disorder, but I have to admit, even in my clinic, we have to classify some of the cases as idiopathic if we don't find a specific cause of this disease. Don't worry, I will not go through genetics. If you have tough questions, ask Luis afterwards on this. Just briefly mention the ones that are of interest for me. I think that you should heard about autosomal dominant hypocalcemia. There you have a mutation in the calcium sensing receptor, a shift in the set point. So the calcium sensing receptor is more or less signaling there's enough calcium there, but it isn't there. So you have a downregulation of PTH. And for the autoimmune causes, the problem, the challenge that we have in the clinic is we do not have an antibody that is approved for routine use that we can measure to say this is autoimmune, the cause of hypopity. But we can test for genes, and there's this IRA gene, and this is causing this autoimmune polyendocrine syndrome, where you also have associated with hypopity primary adrenal insufficiency and other disease entities. So at the end of the day, if it's not surgical, if it's not due to thyroid surgery, the hypopity, you have to figure out, is there a specific cause? And therefore, we recommend genetic testing, family screening in these patients. There are genetic panels available. I know that the situation is often different, but you should try your best to aim for a diagnosis because this matters for the patient. If it's a polyendocrine autoimmune syndrome, then you have to take care of this patient, look for other diseases. If it's a genetic cause, and this can well be that it is diagnosed during adulthood, then you also know something about family risk, you also know something about associated comorbidities, so always try your best to figure out the cause. So with this, I'm more or less at the end of the lab value. I just want to remind you again, hypocalcemia is what we are looking for, and whenever you see hypocalcemia in the clinic, next step is confirm it, measure PTH. As I have shown you this picture, on the x-axis calcium and PTH to make your correct diagnosis. And don't forget also about the other laboratory parameters that you will hear about by the next speakers. So this was the lab. What about the clinic, the clinical symptoms? And this is what we learned in the textbooks during medical school. The classic neuromuscular hypocalcemic symptoms, they can be very different. So paresthesias in the fingers, for example, muscle cramps. In extreme cases, of course, also seizures, laryngospasm. So this can be very severe, but hypocalcemia is doing a lot in your body. It can affect many different organ systems. Also the heart, QTc prolongation, etc., heart failure. And talk to your patients. Many of your patients with chronic hypopity will also suffer from reduced quality of life, fatigue, brain fog. You will hear about this later on, but this is really a burden for these patients. In addition to these clinical symptoms, whenever you approach a patient with chronic hypopity, you must be aware that these patients are at risk for several other comorbidities. In the center of our taking care of these patients are, of course, renal complications, but there's much, much more about these infections, cataract, etc., problems in the neuropsychiatric area, and so on. So you really have to have a holistic approach to take care of your patients. And we have data suggesting that these patients with chronic hypopity, they do have an increased risk of mortality, at least in observational studies. And therefore, monitoring is very important to figure out whether there are complications, whether you can optimize the patient care, the treatment. This is very critical because this is a long-term outcome that we have to bear in mind that we want to optimize for these patients. There are several special situations when taking care of chronic hypopity. I just picked out one that I'm very interested in and that matters a lot, and this is pregnancy. During pregnancy, there are a lot of changes in calcium and mineral metabolism that you should be aware of. You also have a loss of bone mineral density, in particular during lactation and the recovery afterwards. And just some quick takeaways for you. When you take care of patients with pregnancy, you should know that there are changes in laboratory values during pregnancy. So the total calcium level is usually low. So don't rely on the total calcium in pregnancy. Should either use the albumin adjusted or even better, the ionized calcium. And also PTH is lower in pregnancy as compared to the non-pregnant state. So it can be just normal if the PTH is slightly reduced. Why is it reduced? Well, you can say that the function of PTH is somehow replaced by other hormones. For instance, PTH-related peptide or calcitriol, they are upregulated. This is what you should know. And when a patient asks you, can I get pregnant? I suffer from chronic hypopity. Yes, you can pregnant. And the chances are very high that you will have an uncomplicated pregnancy. This is what we know from the literature. But you have to have a good disease control, and you have to know that you should go to regular checkups because we have some changes, either more or less of the supplementation that is required during pregnancy. So just a brief look on pregnancy. And with my last slides, I have now finished more or less the diagnosis part. I want to talk a little bit on the pathophysiology also when it comes to treatment. Of course, treatment indication is clear. If the calcium is very low, we have to start treatment. But also if the calcium is just slightly reduced, and the patient tells you, I don't feel any complaints, I don't feel about or recognize no hypocalcemic symptoms, you should offer treatment because this can improve the quality of life in this patient. And always be aware that patients may adapt to low calcium levels. So sometimes you see patients with very, very low calcium levels not complaining of any symptoms. They've adapted to it. But they will likely feel better if you treat them. And symptoms of hypocalcemia do not translate directly to circulating calcium levels. So it's not only the calcium level that tells you, is the patient doing good or not good? It's required that we have a more holistic approach to this. And you've seen this slide before. I just want to present you the big picture of the treatment of hypopara. I've told you before it's a 2-hormone deficiency, and therefore we have 2 therapeutic approaches. The one approach is conventional therapy. This means we replace just one hormone, that's the active vitamin D hormone. And the other approach is the new treatment, the PTH replacement therapy. This replaces the PTH effect, and because PTH also increases calcitriol, of course also calcitriol. So from a pathophysiologic point of view, this is the ideal treatment for our patient. But there are differences between conventional therapy and PTH replacement therapy that you should be aware. First of all, the primary goal, you will hear about this, in the treatment of hypopity is to maintain calcium levels within the lower part or slightly below the reference range. And you may ask, why not just say a normal calcium level, as it was before? Why is the target in the lower half of the reference range or slightly below? This is because we want to avoid harmful overtreatment with the conventional therapy, because the PTH effects of increasing renal calcium reabsorption and renal phosphate excretion are minimal or missing in chronic hypopity, and therefore, and this is very critical for the understanding of how you approach conventional therapy in hypopity, the aim to increase calcium levels with the conventional therapy with activated vitamin D treatment comes at the expense of an increased risk of hypercalciuria and hyperphosphatemia, because this is exactly the effect of PTH that is missing when we use conventional therapy. But, and this is now the difference, conventional therapy to the more optimal, perfect therapy, I would say, for hypopity. When we use pyrrolobacter, the PTH effects to increase renal calcium reabsorption, phosphate excretion, mitigate this risk of hypercalciuria and hyperphosphatemia versus conventional therapy. So it's, you can say in simple words, it's more safer. to use PTH replacement therapy when you look at these potentially harmful effects of conventional therapy. And therefore, and it's also written in the guideline, it's the first guideline that specifically addresses the differences between the target ranges for conventional therapy versus the PTH replacement therapy. We consider it reasonable to aim for a target calcium level within the lower half of the normal range. No need to go below. It may also be reasonable to aim for calcium levels within the normal range as recorded before the occurrence of hypo-PD, because this is the physiologic level as we can assume for our patients. Having said that, I have to admit, being on this guideline panel together with my colleagues, that a lot we recommend in this guideline on hypo-PD is based on relatively low quality of evidence. But, and I've stolen this from Olaf Deckers, in the absence of strong evidence, we cannot abstain from guidance because the evidence is not solid. So some of the recommendations are based on quite relatively low evidence, but we did our best to provide you a useful guidance for your daily clinical routine. So to sum it up from my talk, we've learned that chronic hypopPD is hypocalcemia and low PTH. The main cause, of course, is surgery. But if there are non-surgical cases in your clinic, try your best to figure out whether there is a genetic cause or an autoimmune cause. And the laboratory diagnostic workup includes not only calcium and PTH, we also have to determine these other parameters to make a proper assessment and then a follow-up and then an optimization of the care that we take of our patients. So with this, you can still relax. We come to the clinical cases. I have prepared some clinical cases, and you have a flag here with the red and the green. And if I did a good job, you will answer correctly. If I did a not so good job, we will see. I just want to go with you through these cases, so no need to answer. Some of the question I will answer myself, and then you correct me if I'm wrong. Got it? Okay. So we start with the 60-year-old woman referred to you for further workup of hypocalcemia, diagnosed at the GP, no thyroid surgery. We always think about previous thyroid surgery in these patients. Apart from measuring calcium, which laboratory test do you primarily order? So you have hypocalcemia. The next test is to confirm it and to measure one parameter, and this is PTH, of course. PTH is also low, so my first question, is chronic hypopara the most likely diagnosis in this patient? What do you think? The calcium is low, the PTH is low. Give me the sign. Is it yes, green, or is it no, red? I see the green light for most, so this seems, if Neil is holding up the green light, I know I'm correct, so thank you. So, okay, this was quite easy. What if the same patient would have identical total calcium, but the PTH within the normal range? So the PTH is normal, but the calcium is significantly reduced. Is chronic hypo-PD still the most likely diagnosis? PTH is normal. Do you think it's yes? I see green light, so thanks, Neil. Which additional laboratory tests should be considered in this patient? This is nothing to answer for you, just to think about. You have calcium, you have PTH. What are additional measures you should order in the lab? Well, I've listed here, of course, the magnesium, the vitamin D status, the phosphate, also always the kidney function, albumin, if you go to rule out whether it's just hypalbuminemia, urinary calcium, etc. So you have to get a broad picture of the laboratory values in these patients to take optimal care of them. And then, that's for you as the residents, what are typical questions in a patient-doctor conversation? So what the patient is sitting in front of you, what are the questions you ask, you consider yourself to ask the patient? This is not right or wrong. This is maybe an approach that I do. Of course, I ask them, do you have hypocalcemic symptoms? That's always a question when you take care of those patients. So paresthesias, cramps, etc. They will tell you if they suffer from this, but ask them. Always the question with chronic hypo-PD, did you have thyroid surgery? If yes, when was the thyroid surgery? Because you know there's a high potential of recovery if a very recent thyroid surgery was there. And of course, we have to ask on medications. Why medications? Medications that have, on the first side, nothing to do with calcium metabolism, but I don't know whether you can read it, but a lot of medications do have an impact on calcium. The diuretics, as we know, glucocorticoids, they suppress vitamin D metabolism, calcium absorption. Then, of course, you know there's osteoporosis drugs, the anti-resorptive drugs. They are contraindicated when you have hypocalcemia. This is what you should know. And what matters for the patient with chronic hypo-PD are PPIs. So they also reduce the absorption of calcium, magnesium. So this is something you should consider to optimize also this additional treatment. Maybe say, is this PPI really necessary? If not, put it away. What if we go on further? The same patient with the total calcium that is reduced and the PTH with normal range reports on absolutely no symptoms, no previous surgery, but appears to be malnourished with marked hypalbuminemia, significantly reduced albumin. And I have been consulted many times for exactly this laboratory constellation. So, which laboratory tests should be considered? I will answer this, but think about what would you do? Which test would you order? The ionized free calcium. Why? I want to figure out whether there is actually hypocalcemia there, or whether the hypocalcemia is just a reflection of the hypalbuminemia. And this is a very frequent reason for consultation of the endocrinologist, at least in Austria. So, if the ionized free calcium is normal, do you still consider chronic hypo-PD as the most likely diagnosis? So, ionized is normal. Do you consider as the red flags? You're very smart people in this room. That's great. What if, again, the same patient with total calcium of 7.8 and PTH within the normal range had thyroid surgery last week, so very recent thyroid surgery, and reports on hypocalcemic symptoms with paresthesias of the fingers? Is the diagnosis, be careful, of chronic hypoparathyroidism correct in this patient? No, it's not correct. Why? Because it was very recent, the thyroid surgery, and we know we have a high potential for recovery in most of those patients. The patient already receives calcium plus vitamin D supplements. So usually the surgeons in Austria, they say thyroid surgery, we send them home with calcium vitamin D supplementation. We do a regular checkup of this. There are more sophisticated approaches to this. You can measure PTH on the first day after surgery. If the PTH is above 10, you are safe. You will not develop hypo-PD. If it's below, you are at a certain risk to develop hypo-PD. But you add calcitriol to this patient, and the patient asks whether this means, because calcitriol is required, that lifelong hypo-PD therapy is required. So will this patient likely have to take calcitriol for the whole life? No, because we know the potential for recovery is very high in these patients. And also when you see these patients, always consider to down titrate the supplementation. So not let the patient remain forever on a supplementation therapy that was initiated immediately after surgery, because the recovery potential is so high. Don't overlook that. And always consider hypocalcemia is something that the patient recognizes. Paresthesias, cramps. Hypercalcemia, if you overdo the treatment, is often not immediately recognized by the patient, but the patient will at some time pop up in an emergency department because of acute kidney failure. So this is something, not overlook this. What if the patient is just 20 years old with total calcium of 7.8 and the PTH within the normal range of 20? She didn't have surgery, but chronic hypo-PD is definitely confirmed by additional laboratory tests. How can you further clarify the etiology of chronic hypo-PD? I will answer it for you. So no surgery, but hypo-PT, a young patient. What should you do if you have the possibility to do this? You should go for genetic testing and consultate Luis after you have the results for this. Also do family screening just to figure out if there is a specific cause of chronic hypo-PT in this patient. I hope in the future we will have approved antibodies that we can measure to detect the autoimmune process in hypo-PT, but we are still not yet there. That is routine care. Genetic tests reveal pathogenic mutations in the IRA gene. What is the implication of this test result? So this was the gene, if there are mutations, that is responsible for this polyendocrine, for this autoimmune polyendocrine syndrome, because there are several associated diseases with this pathogenic mutation. What if we go on with the patient? An apparently healthy woman is 30 years old and pregnant, first trimester. Total calcium is the same, a little bit reduced. PTH also slightly reduced. Which laboratory tests should be primarily ordered? So a pregnant woman, total calcium slightly reduced, PTH slightly reduced. Is this chronic hypo-PT, yes or not? Which test should we do to figure this out? Ionized free calcium and or albumin adjusted calcium, because I've shown you the total calcium is usually lower in pregnancy. This is normal. So we have to rely on ionized and or albumin adjusted levels. And the ionized free calcium, this was normal within the reference range. So we can consider this as normal or physiologic in this patient. Don't assign a diagnosis to a woman who has slightly reduced PTH in pregnancy. Is the message. I've done this in the past, but I have learned and improved. So, with this, I'm at the end of my presentation. I'm happy to take your questions. For me, the easy ones, the tough ones for Luis. Thank you. Anything you want to ask me? Taking care of chronic, maybe raise your hand. Who has ever taken care of chronic hypo-PT patient, or is there anyone? Yes. So you've seen these patients. Has anyone ever used a PTH replacement therapy? So you have done this. Yeah, great. You're in a good way. Anything you want to know from us that we can help you taking care in the clinic? Do you use calcitriol or alpha-calcidol in Portugal? What's more preferred? Calcitriol, so we're the same in Austria. So, I mean, the basic message was what I told you is the hypercalcemic symptoms that the patients recognized, but take care not to overdo it with the treatment. Always this will be part of other talks, always when you change something in the treatment, you have to do a very near follow-up for the patients, because the danger is to overlook that you overdo it and to cause hypercalcemia in this patient. And listen to your patient. This is also what I learned. You will hear about quality of life. You will hear about I'm so fatigued and so on. Many are not able to work. So it really matters that we optimize the treatment. And regarding the diagnostics, well, we want to reduce the number of idiopathic cases when we diagnose patients. So go for the genetic panels if there's an opportunity, because even in adulthood, there can be patients who suffer from a genetic disease, but that's not recognized when they are younger. Yeah, one question.
Congratulations for the presentation. Just a quick one, and I realized that you were discussing with Luis before the session the ionized calcium versus the total calcium.
Yeah.
In Portugal, in many hospitals, we just have either plasma total calcium, and we correct it for albumin, or a quick ionized calcium, whole blood, that is performed in the wards in the lab machine that we use for blood gas. If you just have these two options, which one would you prefer? We don't have a proper plasma ionized calcium. Either whole blood from a quick machine or the plasma total calcium corrected for albumin.
I mean, that's a tough question, and it also depends on the situation and who's taking care of these patients. My experience in the clinic is that most of my colleagues are very familiar, of course, with the total calcium and the albumin-adjusted calcium measurements that you have. So this is okay, I would say. But as I said in the beginning, in a perfect world, we would always try to figure out what's the ionized calcium. But I have dived a little bit into literature on measurements, and I'm not a laboratory guy. There are so many pre-analytical and analytical challenges, and there are also very different ways on how to measure this. But if you do it the way you do it with a blood gas analyzer, you have to take care that the samples are immediately brought to the lab and the measurement is immediately done. So I can only reiterate what I've shown you. So if everything is more or less okay, total albumin-adjusted calcium is fine. But if you struggle with the diagnosis, or you have a very critical, challenging case, for example, a woman during pregnancy and so on, then I would go, if I can reliably measure it, with the ionized free calcium. But yeah, everything has pros and cons, advantages and disadvantages. And we also, as the guideline committee, have to admit, yes, this is challenging, but we want to deliver an easy method. Every parameter of those is okay. If it's challenging, go for the ionized. This is my subjective personal opinion that may differ from some of my other colleagues, I have to admit.
Are there any further questions? No? I have a few, if you don't mind. So you talked about the B hormonal deficiency and some B hormonal deficiency in the chronic hypopity. And it's quite frequent to see some colleagues that prefer a higher amount of calcium and lower amount of active vitamin D, while others prefer to have it the other way around, so having more active vitamin D and lower amounts of calcium. Having that in mind, do you have any preference, any experience of choosing one instead of the other? We know that in the US they do more calcium than active vitamin D.
Yes, I mean, this is a critical question for taking care of hypopara patients. So you have this conventional therapy, you have your calcium supplements, you have your active vitamin D treatment. How to balance these two treatments that you have with conventional therapy. And when we are in Europe, usually we prefer more the active vitamin D treatment to uptitrate it and to use lower doses of calcium. And when you're in the US, you will use more calcium supplements. This is what we know from the literature. But from a pathophysiologic point of view, it makes no sense for me to increase the calcium supplements to very, very high doses. Also, what we did in the past, we over-supplemented them. Also in Austria, that was probably also my fault. I also learned divide the doses, not use doses more than 500 milligrams at a single dose. And we have very good data also from the UK showing that many patients with chronic hypopity, even on conventional therapy, can be well managed without any calcium supplements if you supplement them with the activated vitamin D. So I'm more on the side we have a hormonal deficiency, and if we correct the activated vitamin D, we correct this hormonal deficiency, and then the gastrointestinal absorption will be normalized, hopefully, and then in some patients you can even treat them without any calcium supplements. So this is my approach. However, having said that, there are some situations where calcium supplements may be helpful for you. For instance, you should take it with the meals for better absorption. or you go with calcium citrate. But if the phosphate is very high, and this can help you to add or to increase the calcium dose. But at the end of the day, think of your patients. If your patient has to take so many calcium supplements a day, this so-called pill burden that we have with our patients. Look at the report of the patient. If you see a patient taking pill all the day, you can reduce the pill burden if you increase, for most patients, the activated vitamin D and not increase the calcium. But what I learned from colleagues, whenever I talk with non-endocrinologists, they always think about, okay, more calcium, more calcium, more calcium. I always tell them, the game changer is the activated calcium, and not whether or not you add 500 milligrams a day to a patient with calcium supplements. The game changer is the activated one. But the therapeutic window is also narrow with the activated vitamin D. You can overdo it. Okay. So that's my subjective personal approach that may be different from the other ones in the audience.
Yeah, you would, from the audience, do you usually do more active vitamin D or calcium supplements? Which green for active vitamin D and red for calcium supplements? Okay. Mixed.
It's mixed like in the literature. So there are some guys from Harvard here in the room. Yeah.
So I have another question. The time factor in hypo-PT. So for instance, if you have a patient that underwent surgery at 30s and became with symptoms of hypo-PT at 40s, would you consider it secondary to surgery, or you would go through genetic testing, and if genetic testing is inconclusive, would you consider it secondary to surgery? Yeah. And on the other way around, once a person got the diagnosis of hypo-PT, is it irreversible, or should we retest the patient to check if there's any residual function that may come back and free the patient from the treatment? Yeah.
So the second question first. So if you have patients with chronic hypo-PT, thank you for this question. You always have to reconsider whether the diagnosis in the first place was correct. So we see those patients where someone started a hypo-PT treatment with activated vitamin D and the diagnosis was not even correct. And there is some potential for recovery in those patients. So from time to time, we should reconsider whether PTH is measurable, whether we can reduce the dose. So even in the long run, there's time for recovery. And regarding the question on the timing after surgery, at least in Austria, I see sometimes patients that had thyroid surgery 10 years ago. An old woman in Austria from the Alps is coming once in a lifetime to the university clinic. She had thyroid surgery 10 years ago. I measure the calcium and it's extremely, extremely low. But she has no symptoms because over the years she adopted to a very, very low calcium level. I would still consider this due to thyroid surgery. I cannot prove it. But as a very important clinical hint for you, for your daily clinical practice, when we talk about calcium, the human body regulates the calcium within a very, very narrow window. So the intra-individual variability of calcium is very low. The reference range is much larger than the intra-individual variability of the calcium. And you can make use of this. Watch out for previous older calcium levels in your patients. Because when you know the inter-individual variability is very narrow, then you see some up or downward trend of calcium. This can help you to say, well, something is going on, something is not as usual.
Okay, thank you, Stefan. One last question, just to take advantage of your experience in that field, and because the residents in Portugal help a lot in managing the pregnant woman with endocrinological issues. What do you consider stable for a patient with hypo-PT to become to get pregnant. 1 year of stable doses and the levels are not fluctuating. Do you need more? Do you need less? Because we know that when they get pregnant, it's unpredictable.
Yeah. That's a very individual question for the individual patient. And usually my experience is when they approach me, they want to get pregnant, and I cannot avoid this. But I just tell them, okay, you have to have a normal calcium level in the lower range. If this is on 2 occasions the case, then we go on with pregnancy. And regarding pregnancy, of course, the question comes up: what will happen in pregnancy with my treatment? If you're well controlled, just remain on your treatment. You know, for thyroid problems, so someone who is taking thyroid hormone replacement therapy, you have a positive pregnancy test, you have to increase the dose a little bit in pregnancy. For hypo-PT, stay in your same treatment, so conventional treatment is absolutely fine in pregnancy. The challenging question is when a woman approaches me already on PTH replacement therapy and she want to get pregnant, and this is something very critical and special situation. I would look out to see what was the reason in the first place why PTH replacement therapy was initiated. And if this reason was really there, so she wasn't doing well with conventional therapy, I would say, okay, we have huge uncertainty in pregnancy, but I had pregnant women with PTH replacement therapy in pregnancy without any adverse effects, and I know Maria has patients there. So I would rather say if conventional therapy was not working properly for this patient, this would put the patient at risk during pregnancy. This is a risk we have to consider and to balance against the risk of some unknown effects of PTH replacement therapy in pregnancy. But in those cases where we really had an indication for PTH replacement, I would remain on this therapy throughout pregnancy. But this is my personal opinion, and we have to encourage everyone to publish cases on pregnant women. Of course, and we have a lot of patients with chronic kidney disease, because this is a complication. It's often getting tougher and tougher, but more or less we try to remain within our treatment goals. So the calcium on conventional therapy being the lower end of the reference range or slightly below. We face the problem, of course, with hyperphosphatemia, but when you read the new guidelines, it's more easy for me, because if the GFR is below 60, I will seriously consider to start with all of those patients the PTH replacement therapy. So I will go for Palopec, for Yorvipath in these patients, because we know there's a significant improvement. It's more than 10 ml per minute that you improve your GFR in the long run in this extension phases of these trials. So you will do something good for the renal outcomes if you change it to PTH replacement therapy. But one thing that always pops up in my mind is the more advanced the chronic kidney disease, and this is my subjective impression, the more of a dose I need for a PTH replacement therapy, because when you look at PTH in CKD patients, you see that the PTH rises, in particular in advanced stages, and there's this concept of PTH resistance. So I told in the beginning, it's the high phosphate that stimulates PTH. It's also that maybe the measurements with the immunoassays are not working properly because they're detecting fragments and so on. But it's also that there is this resistance of PTH, so you may need a little bit higher dose, in particular when it comes to end-stage chronic kidney disease. There it's not approved, but I have patients with that, and they probably need a higher dose. But it's becoming more and more challenging, of course, with these patients, and I'd be very, very cautious to overdo it. So rather a little bit lower than too high. You know, calcium, having a too high calcium is not a good idea for a damaged kidney. But thank you for this question.
So Thank you, Stefan, for your presentation and for the discussion. Now we will move on with Neil Guitos and Miguel Melo for the next section. Thank you, everyone.
Thank you.